Good morning, everyone. I'm Dr. Anupam Raj, Senior Consultant Anesthesiologist from Indraprastha Apollo, New Delhi. I will be discussing the basic cardiac focus image acquisition. And I also want to thank the AORA academic team for giving me this opportunity to present the topic on this widely loved platform of AORA4U. When it comes to the cardiac focus, it's important to get the good quality images in order to achieve the best out of the information that you are getting through POCUS. The POCUS does not replace the good clinical history and examination, and it also does not replace the standard echocardiography. The idea of basic cardiac focus is only to understand the skill of echocardiography for non-cardiologists in order to perform the cardiopulmonary evaluation and optimization of the patients. And to be able to fully and accurately interpret the data obtained from the cardiac focus, first and foremost step is to be able to acquire good and the best images and to be able to troubleshoot the common problems of image acquisition. The learning objectives for today's session is going to be to understand how to acquire these basic cardiac views, to recall the basic applications, and to troubleshoot the various common problems that we encounter while acquiring these images. You can use whichever machine that you have. The probe that you will be required for the cardiac purpose would be a phased array probe. And different machines have got different orientation marker. The G machine usually have this long sort of line, which is corroborating with the orientation marker, this here. Many of the Sonosite machines have a dot. So make yourself familiar with your machine and your particular phased array probe and where the orientation marker is pointing. There are various ways to hold the probe, and it could be a screwdriver grip or a pencil grip. The grips can also be the overhand or underhand, in which have got different uses when we are trying to acquire the images. Many times when we start learning the cardiac focus and acquiring these images, we just put the probe and we hope for best that we're going to get an image. However, there are very specific movements that are involved so as to acquire the best images that we can. And these images, these movements have got this particular name, sliding, where you move the probe up and down or to either direction without really changing the or tilting the probe or changing any sort of angulation. Then comes the tilting, where you're trying to move the probe in an axis which is perpendicular to the axis of the orientation marker. Then comes the rotating, where you're only rotating the probe clockwise or anti-clockwise. And then is the rocking, where you're trying to move the probe in a direction which is parallel to the orientation marker. So like you can see here, this is the rotation where you're moving the probe clockwise or anti-clockwise. Also note there's no change in the angulation while making these movements. Again, sliding, going up and down or to the right or the left without changing any angle. Then comes when you're moving the probe along with the orientation marker and or when you're trying to move the probe in the direction perpendicular to the orientation marker. The other things which are required for the best image acquisition is the gain, the knowledge of gain, depth, sector angle, and time gain composition. Now, these are the basic understandings which we do when we start learning ultrasound, and I'm not going to go into the details of these things. However, understand your machine and we will be fixing each of these when we are acquiring the images. Now, the basic views that we are going to acquire while doing the cardiac focus include the subcostal four-chamber view, apical four-chamber view, parasternal, short axis view, or a long axis view. Apart from these, we can also achieve an IVC view, which is very quick and easy and provides additional information over and above the four basic views. So we will be discussing that too. Coming to the first subcostal four-chamber view. Now, this is the picture of a classic subcostal four-chamber view that we're going to achieve. And this is the position how the patient is usually lying supine. The subcostal four-chamber view is suitable for the pathology like the pericardial effusion, pulmonary embolism, wall thickness, chamber dimensions, biventricular function. This is also a very easy view that can be easily achieved at the time of the cardiac arrest without requiring to change the patient's position or interfering with anybody else's work who's working on the head end of the patient. So it comes in really, really handy in the cardiac arrest situations. Patient position is usually either supine or sitting. Transducer position is positioned subcostally and slightly to the right of the midline. Orientation marker is usually directed towards the left side. Depth is set at 16 to 24 centimeter. Hold the probe in an overhand grip. The reason being that you're going to dig into the patient's abdomen to get the best view. So if your hand is in an underhand grip, if you're holding the probe from below, then it'll obstruct in getting the good image. So hold the probe in an overhand grip so that you can get the best image. Now place the transducer subcostally, slightly to the right of the midline, orientation marker directed towards patient's left at almost 3 o'clock position. And now as right atrium and right ventricle are placed anteriorly, they will appear in the near field and LA and LV will appear on the far field. The classic picture that we get is this, where we are scanning the heart through the liver and we're able to see the RV, the tricuspid valve, right atrium, interatrial septum, left atrium, mitral valve, and the left ventricular valve and the interventricular septum. To obtain this for the view, basically, like I said, that the position is subcostal or subxiphoid with the orientation marker pointing towards the 3 o'clock position, and you can try and slide the probe towards the right side in order to visualize the best image if you're not able to get a good acoustic window by directly pointing it in the midline. The forced expiration tends to bring heart closer to the ultrasound probe and thus helping improve the image in this particular view. Coming to the IVC view. Now, this view is required for the quick evaluation of IVC dimensions, IVC dynamics with respiration, placement of umbilical catheters in neonates, and IVC dynamics for the optimization of fluid responsiveness. And to achieve the inferior vena cava view, there are two basic ways. One is that you get your subcostal view and then proceed from there. The particular image that you're trying to acquire is this, where you are able to see the IVC in the longitudinal section. You're able to see hepatic vein draining into it, and you're able to see both opening up into the right atrium. So to get this view, start by getting a subcostal view, and from 3 o'clock position, move the orientation marker, which is now facing cranially exactly. And at the same time, you need to lift the probe up as if you're trying to look at the behind the back. So this is the classic picture that you will get where you are scanning IVC through the liver. And because the IVC intersects through the liver, you may be able to see the liver tissue both above and below the IVC. You'll be able to see the hepatic vein opening into the IVC, and you will be able to see the right atrium. Another important thing here to notice that, both the abdominal vessels, the aorta and IVC lie side by side. So it's important to identify and not make a mistake of identifying aorta and thinking that this is IVC. There are various factors that we need to incorporate to understand that. Aorta tends to be pulsatile, more rounder, the thick walls are very clearly visible. If you're accidentally seeing the aorta, you won't be able to see the hepatic veins draining into it, and you won't be able to see it opening into the right atrium. So it's important to acquire this complete image. Another way of acquiring the inferior vena cava view is through the short axis of the abdominal vessels. And in this, we first cut both the IVC and the aorta at a perpendicular level behind a vertebral body. And then here again, the orientation marker will be at 3 o'clock, and you are looking straight into the patient's stomach. And then slowly try to move the orientation marker so that it now faces cranially. And while doing so, keep an eye on the IVC and try to follow it. You will be able to acquire an image where it's opening into the right atrium, and you will also be able to see the hepatic vein opening. Now, for troubleshooting, now the patient should be lying in the supine and with the arms resting on either side. If possible, ask the patient to fold the legs so as to relax the abdominal muscles. This will help you maneuver your probe easily. Now, the orientation marker should be pointed towards patient's left side directly, like I said, 3 o'clock position, rather than towards the patient's shoulder. And if the chambers are not open, try tilting the probe up and down gently and rotate 10 degrees counterclockwise to get the desired image. If the aortic valve is visible, the tail of the probe should be tilted upwards. And if you get a lot of lung shadow across the apex, move your probe to the right side. Deep inspiration tends to improve the image quality because the heart basically comes closer to the probe. The next view that we're going to discuss is the apical four-chamber view. The best image will have, you will be viewing the heart from the apex, the area where the apex beat is where either it's visible or is palpated. And because you're viewing it from the apex, you will be able to see both the ventricles closer to the field, and atria would be away from the field. This particular view is very suitable for the analysis of the wall thickness, chamber dimensions, for various Doppler calculations, and also for the tricuspid and mitral valve pathologies. To obtain the view, the optimal position of the patient is where he's lying 45 degrees in the left lateral position. Image improves with expiration. Place yourself on the right side of the patient and pencil grip your transducer in the right hand. Now place the transducer at the apex beat. Orientation marker will be directed towards patient's left side to left shoulder. Adjust the transducer in small incremental tilts and rotational movements until you get the desired image. And depth is usually 14 to 18 centimeter. So again, highlighting that the transducer, apical four-chamber view is obtained by placing the transducer where the cardiac apex is most easily palpated. In a thin patient, you might actually be able to see the apex beat, and then you can easily place your transducer there. Orientation marker is directed towards patient's left side. Now, as the transducer is placed at the apex, both the right ventricle and the left ventricle will appear in the near field, and right atrium and left atrium will appear in the far field. Now, the structures that we will be seeing, the ideal image should have a absolutely straightened intraventricular septum. In a normal patient, a large U-shaped LV and a V-shaped right ventricle would be seen. However, the size and shape can vary depending upon the patient's pathology. And then the atriums and the right and left atrium will also be seen. Now, when the patient expires, the image tends to improve because it takes the lungs shadow away from the heart, and that's how it helps. When you are seeing a diagonal interventricular septum, rocking of the probe tends to help, or you can also slide laterally to get the best image. Sometimes we tend to see a globular heart, that is because of the foreshortening. And if the aortic valve is visible, then you need to lift the tail of the probe. And if the coronary sinus is visible, lower the tail of the probe. Now, this is the video presentation of how to fix a diagonal heart. Basically, to fix this, all you need to do is gently rock your probe and you will be able to achieve the best straightened IVS. On the contrary, you can also move your probe to the left side and thus help straighten the IVS in most patients. And this is a view where you will be able to, if you're seeing too much of the aortic valve, like I said, you need to lift the tail of the probe and then the aortic valve will go away. And the other problem that we usually see is the foreshortening, where rather than cutting the heart from the apex, we tend to cut it at a wrong angle. And because of this, what we see is a globular heart. Now, the problem with this sort of heart is that, if you put your Doppler calculations here, you will be able to you will be getting the wrong findings. And this will also tend to overestimate the left ventricular function because it will look like as if it's contracting very, very nicely. So to fix this image, you just need to move one intercostal space downwards and you will be able to get a better image. Coming to the next views that we'll be discussing, that's the parasternal views, and there are two of these, the long axis and the short axis. Parasternal long axis view is one of the most easy view to get, and the classic view, you will be able to see the right ventricle, left atrium, and the LVOT tract, and the aortic valve here. The patient is usually again positioned on the left side, and this is a very good view to evaluate the pathology, pericardial effusion, pulmonary embolism, wall thickness, chamber dimensions, bioventricular function. The optimal position of the patient here is 80 to 90 degree in the left lateral position. Image improves with the expiration again because the lungs are taken out of the picture here. And place yourself on the right side of the patient, pencil grip the transducer on the right hand and place it in the intercostal space 3rd to 4th, close to the sternum. Orientation markers should be directed towards patient's right shoulder. Now, it's important to remember that this is probably the only view where your orientation marker is pointed to the right side. For all the other views, the orientation marker is pointed towards the left side. Adjust the transducer position in small incremental tilt and rotational movements to get the desired image. And the depth is usually 12 to 16 centimeter. Now, the parasternal long axis view, your patient is in the lateral position. You're placing the probe close to the sternum at the 3rd to 4th intercostal space to get the image. Also, it's important to realize that, the images that you will be getting, it will also depend upon from patient to patient. Let's say you have a patient which has got COPD, the heart might be oblong, and the actual space where you will be able to get a good parasternal long axis view might have moved downwards. So the orientation marker is going to be on the right side, and the target view is a 3-chamber and an ascending aorta image. Now, RV is located anteriorly, directly under the transducer and appears in the near field. LA and LV are located deeper and they appear in the far field with the ascending aorta interposed between the LA and RV. The apex appears on the left side of the screen and LA and ascending aorta appear on the right side. It's important to memorize exactly what its structure is present. So this is just under the probe is your right ventricle. Left ventricle is on the right side, and then LVOT and aortic outflow. And left atrium is present at the bottom of the screen. This is the pericardium, the white, shiny, shimmery structure. And below that, we'll be able to see the descending aorta. Now, a fluid collection below or above this line will help us identify whether it's pleural effusion or pericardial effusion. Sometimes when, like I said, that it's very easy to acquire this view, but however, sometimes the problem that we face is that we are either seeing a lot of LV or we are seeing a lot of aortic outflow tract. So the simple rocking maneuver usually tends to fix this problem. Like in this image, we can see that, by rocking the probe on either side, we will be either be able to see the LVOT or we will be able to see the LV tract. Like here, we can see that, just by tilting the probe, rocking of the probe, we are either seeing more of LV or we are seeing more of the LVOT tracts. Coming to the next view of interest, which is the parasternal short axis view. Now here we are cutting both the ventricles at a complete cross-section, at perpendicular complete cross-section. So we'll be able to see two round structures, the LV, which would be rounder, and a crescent-shaped right ventricle. The papillary muscles are usually nice and thick in the LV, and this is the exact view that we should be getting, which is called the mid-papillary view of parasternal short axis. To obtain this short axis view, the best is to get a long axis view, how I described earlier, and then you need to rotate the probe clockwise on the 90 degrees, so that now the probe marker is facing towards the left shoulder. Now adjust the transducer position with small incremental tilt and rotation with a depth of 12 to 16 centimeter. To get the parasternal short axis view, your transducer position is same as PLX, that is the third to fourth intercostal space close to the sternum. Now the transducer is facing towards the left shoulder rather than the right, and the target view is two ventricles that we are looking for. Now, RV is placed anterior to the probe and appears on the near field, and the deeper placed posterior wall and papillary muscles of left ventricle appear in the far field. RV appears on the left side of the screen and LV appears on the right side of the screen. So the ideal structure of right ventricle on the top, LV at the bottom with two papillary muscles. The one on the right is the posteromedial papillary muscle and one on the left is the anterior lateral papillary muscle. To obtain, like I said, get the best plaques view, and from there rotate the probe to 90 degrees so that the orientation marker is now facing towards patient's left shoulder, and you will be able to get a view of mid-papillary view of the parasternal short axis. So the ideal view should look something like this, where you are getting the mid-papillary sections of the uh, uh, LV. Now, sometimes while acquiring this view, the problem that occurs is that we start seeing an oval-shaped LV. Now, to fix that problem, basically what we are doing is, rather than, it's a circular cylindrical structure, and rather than cutting it in the middle, we are basically cutting it diagonally, because of which we are seeing the oval-shaped LV. So just slightly rotate clockwise or counterclockwise so that you're able to get a good, nice round LV. The other problem is sometimes we end up seeing either the problem, or this is exactly what you're looking for, that you're seeing too much of mitral valve, or you're seeing too much of the apex. To fix this problem, all we need to do is, tilt the tail of the transducer towards the right shoulder or away from the right shoulder. When we are tilting it towards the right shoulder, we will be able to obliterate the mitral valve view, and we'll be seeing more of apex. And when we are tilting it towards away from the right shoulder, we will be able to get better view of the mitral valve. So this brings me to the fact that, I hope you're able to understand how to acquire the basic 4 cardiac views. You will be able to remember the various applications of these views, and you will be able to troubleshoot the common problems that we encounter while getting these views. I would suggest that, pick one view at a time, go stepwise, and in a stepwise manner, try to achieve that best view. And once you have learned one view, go to the next view, and then you can learn further, one by one. To make this presentation, I have used a lot of online resource, including the POCUS 101, 123, ultrasonography, and USABCD basic cardiac module. I've also taken consent from the volunteers where I've shot the videos. And I would also like to say thanks to all my friends who helped me shoot the videos for this particular presentation. Thank you very much.